Hello, my name is Henry Silverman, and I would like to give a presentation regarding truth-telling in medicine and specifically address the question, can deception ever be morally acceptable or justified in healthcare? First, let's go over some definitions. Most would agree that a lie represents saying something that is not true. In contrast, deception is usually thought of as withholding dismal facts, but not necessarily telling an outright lie. This sometimes is framed as a non-lying deception. Although not considered a lie, this concept of deception brings up the distinction between telling the truth and being truthful. Hence, while one can say that one is still telling the truth if one merely omits dismal facts, one, nonetheless, is not being truthful. This slide shows the reasons for lying in healthcare. First, preventing harm or non-maleficence can be achieved by withholding bad news, as disclosure can cause real and predictable harm. This brings up the concept of the therapeutic privilege, which refers to the withholding of information by the clinician in the belief that disclosure of this information would lead to the harm or suffering of the patient. Examples of the therapeutic privilege includes the withholding of a cancer diagnosis from patients or withholding any type of bad diagnosis from a psychological fragile person. Those who believe that there might be a role for the therapeutic privilege in medicine also caution that it must not be abused. Second, the principle of beneficence or doing good for patients may also justify deception. Examples would include the deceptive use of placebos and also lying for patients on disability forms and health insurance forms. In the latter two instances, however, one must balance the principle of beneficence against that of justice, as lying for patients on disability forms and health insurance forms, while providing extra benefits to individual patients, does financial harm to the general population. Finally, deception can respect autonomy if one reliably knows that the patient prefers not to be told the truth. In contrast, several reasons can be given as to why lying is morally incorrect. First, it may diminish the trust that society has for the medical profession. Second, it demonstrates a lack of respect for persons. And finally, deception can diminish autonomy if patients desire the whole truth so that they can make reasoned decisions. When one invokes the therapeutic privilege, as mentioned above, to justify deception, one is using a form of paternalism that is referred to as weak paternalism. Weak paternalism occurs when a patient lacks important dimensions of capacity to make autonomous decisions or to handle the truth. This occurs when treating a child, an elderly patient with dementia, or anyone who suffers from a mental illness. Weak paternalism is generally easier to justify than its cousin, strong paternalism. Strong paternalism occurs when a patient appears to have full capacities for autonomous decision-making, but the provider nevertheless feels that the patient's decision is mistaken and will cause great harm. Strong paternalism is seen as much harder to justify as it represents a threat to respect for autonomy. As such, it is never justifiable in the doctor-patient relationship. This slide shows a test or an algorithm to consider when one contemplates using deception. First, one should consider whether there are some truthful alternatives to deception that can achieve the same purpose. Next, one needs to determine the moral justifications for the deception. Examples include to prevent psychological harm, the patient cannot cope with the truth, the patient is believed not to want to know the truth, and finally, the deception will enhance autonomy in the future. Subsequently, one should consider objections against deception. For example, if discovered emotional distress or loss of trust may happen. Second, failure to enhance patients' immediate autonomy. And third, violation of norms of honesty. Following this, one must ask, Do the justifications outweigh the objections? Finally, one should ask whether one will be able to defend the deception to a professional body or public jury of reasonable persons. I would now like to discuss the situation in which deception or withholding the truth commonly occurs. Mrs. Lee is an 80-year-old Asian widow hospitalized with weight loss, generalized weakness, and a pulmonary mass. Workup reveals that she has cancer. Her oldest son approaches the physician and asks that the patient not be told, stating that in their culture, the elderly are protected from such distressing news. In mainland China, cancer is considered fatal, and to tell her would be like giving a death sentence, should you respect the son's approach. This slide shows the frequency with which physicians would not give their patients the truth about the cancer diagnosis. In a survey performed in 1961, 90% of the physicians said they would not tell patients a cancer diagnosis. When the same survey was conducted in 1979, 98% of the physicians would tell their patients a cancer diagnosis. The reasons for the shift in attitudes include better training for physicians in the care of the dying patients, legal requirements for informed consent, social trends that include consumer activism, and therapeutic advances in the field of cancer that makes a cancer diagnosis not to be considered a death sentence. Studies have shown that acceptance of non-disclosure of the truth, particularly regarding cancer diagnosis, is governed by culture. For example, Western civilization considers that autonomy is a primary principle, and hence non-disclosure is rarely tolerated. In contrast, Eastern civilizations hold an opposite viewpoint that includes two basic norms. One, decision-making authority lies with family and not the individual who is sick. And second, one should withhold bad news from family members who are ill. Accordingly, full disclosure would violate both of these two norms. One must ask, how culturally bound is the current Western emphasis on autonomy and the need to tell the whole truth to patients? Only a tiny slice of the entire history of medicine is dominated by an autonomy ethic of truth-telling. The majority of other world cultures still seem reluctant to embrace such an ethic. Studies have shown that people from many different cultures are more likely to believe discussing death can bring death closer. This has been particularly seen among African Americans, some Native American tribes in the U.S., and among individuals from China, Korea, Mexico, and the Middle East. This slide shows a study looking at 800 patients in the Los Angeles area of the U.S., in which 200 were surveyed from each of 4 different ethnic groups: African American, European American, Mexican American, and Korean American. It shows dramatic cultural differences in attitudes about end-of-life care. Differences were seen in attitudes around whether a patient should be told that they have a diagnosis of cancer. For example, more than 90% of African Americans and those of European American descent believe that patients should be told of their cancer diagnosis, whereas lower percentages held such an attitude among those of Mexican and Korean descent. That said, for sure, at least some traditional cultures are moving in a Western direction, for example, Japan. Indeed, certain cultures are against what is called truth dumping and consider it to be a violation of beneficence, usually perceived as being cruel and uncaring. Is non-disclosure a violation of autonomy? To answer this question, many ask whether cruel disclosure makes a patient a better or freer decision-making, and also whether a patient gets a voice in how the truth is told. Regarding the previous case study regarding Mrs. Lee, a survey was performed in 2000 to determine what percentage of doctors said they were more likely to abide by a family request to withhold information if they believed that such a request would respect cultural norms. And the answer was 63% of the doctors would honor such a request. So where does all of these data lead us to? Can one advocate for a reasonable mix of beneficence and respect for autonomy? We can take some advice from Robert Buckman, who wrote a book regarding how to break bad news. In this book, he discusses a truth protocol, which consists of the following steps. First, pick a good time and setting and assemble the right people. Second, find out how much the patient already knows. And third, find out how much the patient wants to know. Subsequently, share the information the patient seeks in a sensitive manner and in appropriate chunks. Then respond to the patient's feelings, and finally, plan and follow through. Lessons from Buckman includes the following. 1. Effective truth-telling is heavy on listening to the patient and light on talking from yourself. Second, most patients want to know more and can handle it. A few don't want to. And finally, giving patients a greater role in setting the agenda is respectful of autonomy and is also compassionate and caring. Also, seldom should the question be, should we tell the patient the truth or conceal it from her? Rather, the conversation should incorporate a series of questions, such as when to tell, how much to tell, what exact words to use, whom should be there with the patient, and what comes next. So to summarize, place the choice of disclosure with the patient as much as possible. Follow the patient's wishes. Abide by family only if the patient requests that communication be through the family. Offer the truth. Ask patients what they want to know. Disclose if the patients ask. Tell only if asked. And tell the truth, but as positively as one can without distortion. Thank you very much for listening to this presentation.